Welcome all to the today's class of emergency obstetrics, in which we have next topic as a Vasa Previa and cord prolapse. Okay, so this topic is going to be very important, and this is a green top guideline, very frequently asked in the examination. So first we'll learn about Vasa Previa. Okay, so what about the what is the definition of Vasa Previa? Actually, in Vasa Previa, what we have is the fetal vessels which run in the pre-placental membranes, which are unprotected by the placental tissue or the Vartan's jelly. Okay, so these are the fetal vessels which run through free placental membranes, and it is unprotected by placental tissue or Vartan's jelly. The risk of rupture likely during the active labor or amniotomy. Okay, especially if they are near or over the cervix under the presenting part, the risk of rupture is high. There are two types, type 1 and type 2. Remember, type 1 is a filamentous cord and type 2 is associated with the subcentriate lobe. Okay, we'll see this in the subsequent figure. Okay, so this is a type 1. So what is type 1? Type 1 is associated with filamentous insertion of the cord. So this cord is getting inserted into the membrane. Okay, and here is a placenta, and here there is a feeding vessel to this particular cord. Okay, it is lying free in the membrane. This is type 1 type of Vasa Previa. In type 2, what we have a this subcentriate lobe. Here is a main placenta, here is a cord, and there is a vessel which is connecting this subcentriate lobe to the main placenta. So this becomes the Vasa Previa, that is type 2. Okay, so these are the two types. Is it very clear to you? Type 1 and type 2. Type 1 is a filamentous and type 2 is associated with the subcentriate lobe. Okay, yeah. So what are the key points? First is emergency cesarean delivery. If Vasa Previa ruptures during the labor, then what? Another thing is the neonatal resuscitation facility should be available and should include the blood transfusion if required. Remember, when the Vasa Previa bleeds, the bleeding is going to be from the fetal aspect. So the not only neonatal resuscitation, but the blood transfusion may also be required. And third is a placental pathological examination to confirm the diagnosis, especially if there is a stillbirth or acute fetal compromise. Okay, so whenever there is a scenario about the Vasa Previa, you see what exactly they have given, but option with neonatal resuscitation, including the blood transfusion and placental pathological examination. These three things are very important. Okay, now how it is diagnosed. So diagnosis in labor by vaginal examination, what we feel is a pulsating fetal vessels at the internal os. There may be dark red bleeding and there may be acute fetal compromise after the membrane rupture. Okay, now if it is not diagnosed antenatally, so it happens during the labor, what is the mortality? And if it is diagnosed antenatally, then what is the mortality? Okay, so if the condition is directly diagnosed in the labor without antenatal diagnosis, then fetal mortality is high, more than 60% despite urgent cesarean. Okay, so high fetal mortality to the extent more than 60%. Sometimes they ask you the survival rate. So survival rate will be around 40% if the condition is not diagnosed, while prognosis with antenatal diagnosis will be 90%, 95% survival with ultrasound detection and planned cesarean section. So good survival rate with antenatal diagnosis. Okay, then what is the prevalence? It happens in 1 in 1200 to 1 in 5000 pregnancies. Possibly it is underreported. So these are the few important things about the Vasa Previa. Then what is the emergency management? Immediate cesarean delivery along with the neonatal resuscitation, SOS if required blood transfusion we have to carry out, and after delivery we will send the placenta for histopathological examination for confirmation of the diagnosis, especially after the stillbirth or acute fetal compromise. Okay, then a classic presentation in the labor, it is a painless vaginal bleeding or Benseker's hemorrhage, usually after Benseker's hemorrhage after cervical dilatation and spontaneous artificial membrane rupture. Then fetal risk, fetal blood volume is approximately 80 to 100 ml per kg. Even small blood loss can cause rapid fetal death. Okay, this is SBA. They ask you about the normal fetal blood volume. It is around 80 to 100 ml per kg. This is a frequently asked question. Okay, so here lies a SBA 80 to 100 ml is the answer. And what does the evidence says? As evidence coming from systematic review and meta-analysis says that the perinatal death risk is 4.5 times raised with Vasa Previa. Okay, so prenatal mortality is high with Vasa Previa. Then what is the accuracy of diagnosis? High diagnostic accuracy with low false positive rate with routine anomaly scan, best with combined transabdominal and TBS CDI, that is a color Doppler imaging. So what is the best modality will be transabdominal plus TBS CDI, color Doppler imaging. Clinical diagnosis is not reliable. Clinical method with is not very reliable. Vaginal bleeding in pregnancy has got low predictive value because there are n number of causes for the vaginal bleeding. Okay, so definition we have seen that vessel in the pre-placental membranes within 2 centimeter of the internal cervical os. This definition is modified after the definition of the low-lying placenta. Okay, so generally there is a vessel lying in the free placental membrane within 2 centimeter of the internal os. Timing of screening, around 18 to 24 weeks of gestation, that is somewhere around the malformation scan, and confirm this at 32 weeks of gestation. Okay, so diagnostic, what we have seen, TVS CDI color Doppler imaging in the second trimester, sensitivity is high. Then outcome prenatal, if you diagnose 97% survival rate, we have already seen more than 95% survival rate condition diagnosed, while 44% only they have mentioned 60 more than 60% mortality, and survival will be 44%. Okay, if diagnosed intrapartum. Okay, so these are the important things to learn regarding this. So what are the key points? Universal screening, these are the what we have seen up till now, these are the modalities which are available. But then should we screen all patients? So what does the guidelines say? That universal screening is not supported. There is insufficient evidence for general population. Mid pregnancy anomaly scan is general population has undetermined benefit to harm balance. Okay, so all population not to be screened for this. Okay, what does UK NSC review says? That is National Screening Committee. UK National Screening Committee says there is a little benefit in identifying Vasa Previa in the second trimester, high false positive rate, and around 80% of cases will have more than one identifiable prenatal risk factor. There is no UK epidemiology data for filamentous cord insertion, no evidence to support screening for filamentous cord insertion as a proxy. Okay, so targeted screening for high risk group is preferable. So they don't recommend universal screening, but what they say that high risk group can be screened because more than 80% will have more than one identifiable risk factor. So these high risk patients can have the targeted screening. Okay, so what are the risk factors? 83% of Vasa previa will have more than one risk factor. These common are placenta previa, bilobe placenta, subcentenniate lobe, ART conception, and filamentous cord insertion. So these are the high risk factors which are associated with the Vasa previa. Okay. Now this Australian maternal obstetric surveillance data is there. So what they say that here again more than one risk factor in almost more than 90% of cases, and filamentous cord insertion is seen in 62% of cases, and low lying placenta in 60% of cases. Okay, that was a I think Australian study it is there. So they have mentioned about these are the placenta previa, bilobe placenta, centroid lobe, etc., etc. These are the risk factors, out of which here the all the options are given. Then filamentous cord insertion appears to be more common than low lying placenta. Okay, and 20% of the second trimester Vasa previa will resolve before delivery. So even if you diagnose second trimester, 20% will be resolving before delivery. And if you have diagnosed that, then we have to follow up at 32 weeks of gestation, especially when associated with the low-lying placenta. Okay, and you have to document the cord insertion. Okay, and this American ultrasound medicine, this what do they say? You have to document the placental cord insertion when possible. Okay, American Institute of Ultrasound Medicine mentions that you should document the placental cord insertion wherever possible. So what are the summaries up till now? We have seen universal screen, insufficient evidence. Okay, targeted screening, benefit versus harm still not clear, more research is required. Then UK National Screening Committee, what does they say? 80% cases have more than one identifiable factor. Little benefit from the second trimester screening, high positive rate, and do not implement universal screening. Consider limited target approach for high risk groups. Okay, like low lying placenta, etc. Okay, then we have seen 83%. Then these are the high risk factors which are associated with the Vasa previa. So management of the Vasa Previa, what are the summary points? First thing about we have to go for emergency delivery. Do not delay delivery if fetal compromise is suspected. There is a high mortality with rupture. Immediate cesarean section if PROM or labor at viable gestation. So if the gestation is viable, you go for immediate cesarean section or category 1 cesarean section. We'll discuss about all categories subsequently in our sessions. Okay. Then elective delivery. Confirm Vasa Previa in the third trimester, elective cesarean section before the onset of labor. Okay. If it is confirmed in the third trimester. Then hospitalization, consider from 30-32 weeks based on the risk factors like multiple bleeding, threatened preterm, etc., etc. And so these are the few summary points. Then ultrasound confirmation, we have to reassess in the third trimester to confirm the persistence before planning delivery. Cervical length, if the cervix is becoming very short, then these patients are likely to bleed, okay, or they are likely to land up in the problem. So that is one of the thing which they have mentioned. So timing of elective delivery in Vasa Previa. So all timing of the delivery in all cases you should know. So what is the timing for Vasa Previa? Goal is deliver before membrane rupture while minimizing the iatrogenic prematurity. So recommended timing is between 34 to 36 weeks. Remember, Vasa Previa 34 to 36 weeks when patient is asymptomatic. So you will plan the cesarean section between 34 and 36 weeks, and corticosteroids from 32 week onwards. So most important, 32 give corticosteroids, and plan cesarean section 34 to 36 weeks. Then evidence and rationale, here longest course was 97% survival when the delivery is around 35 weeks of gestation. Okay, so that is what is the thing, and you don't have to wait for amniocentesis or something like that. 34 to 36 weeks, if you deliver, the outcome is good. So that finishes the Vasa Previa. Thank you.